So thank you for the opportunity to make a short statement at the opening of the public hearing. I have been asked by the Trust Chairman to emphasise at the outset our absolute commitment to meeting our human rights responsibilities and providing high quality and safe care to our diverse population of 300,000. The Western Trust covers the largest geography of the 5 trusts in Northern Ireland and shares an extensive land border with the Republic of Ireland. Although we include the second city of Derry, Londonderry, we are largely a rural geography. We have high levels of social deprivation, unemployment, and a large number of over 75 and 85-year-olds, all indicators of the increased need for health and social care. Our approach to human rights is that we put the patient at the centre of all we do. In recognition of the needs of vulnerable individuals, the Trust has introduced a number of innovations which Mr McKinney will describe later, such as fast-track triage of patients with learning disability and elderly patients' falls assessment and liaison service. We welcome the Commission's focus on this important area of healthcare, as it is also a priority for us to improve emergency healthcare provision. Our ability to deliver effective emergency care is often seen by the general public as an indicator of how well we are providing services overall. We manage 2 acute hospitals, Altnagalvin Hospital here in Londonderry and the Southwest Acute Hospital in Enniskillen. Both have Type 1 emergency departments, seeing 59,000 and 30,000 patients respectively each year. An urgent care and treatment centre in Omagh is part of the Trust's network of emergency services supporting the 2 Type 1 EDs, and it provides a minor injury service dealing with approximately 17,500 patients per year. The Southwest Acute Hospital is consistently the highest performing Type 1 emergency department in Northern Ireland, regularly exceeding the 95% 4-hour standard. Altnagalvin is also high performing. For example, there hasn't been a 12-hour breach in Altnagalvin since January 2014. As today's focus is Altnagalvin, you will hear later from Geraldine Mackay about the ambitious unscheduled care improvement plan endorsed by Trust Board in January 2014. You may have picked up through the media the success of our 100% Day on the 12th of September, when all patients attending Altnagalvin's emergency department were seen, treated, discharged or admitted in no more than 4 hours. This was planned by us as a learning event to test our assumptions in the improvement plan that I mentioned earlier. However, in terms of quality, the Western Trust regularly monitors other measures such as time to triage from arrival, time to medical assessment from triage, time to lysis for strokes, and early recognition and management of sepsis. Although Altnagalvin performs relatively well, we are all committed to further improvement, and feedback from our patients, relatives and staff is an important part of this. We encourage and take account of feedback through, for example, the 10,000 Voices campaign, patient experience surveys and service user involvement in improvement work. I recognise, however, that despite all our efforts, some patients will have had a poor experience of our care, and we look forward to hearing patient stories today as an opportunity for further learning. Our greatest strength is our dedicated and committed workforce, but workforce is a particular challenge for the Western Trust in emergency care. I am enormously proud that staff have consistently risen to every challenge they have faced, such as dealing with the impact of the fire in Altnagalvin in November 2012, flooding at Letterkenny Hospital in 2013 and again in 2014, and indeed on Monday of this very week when they responded to a serious road traffic collision in Drumquin. However, because we are the farthest west in the UK, we find it difficult to recruit and retain doctors to enable us to guarantee patients access to senior decision makers on a 24/7 basis. The Commission will note the small number of emergency department consultants posts we have in Altnagalvin in comparison to other Type 1 EDs in Northern Ireland, and it is for this reason that we have been focused on identifying a local solution to a local problem. The culture of the Western Trust is a relentless focus on quality, safety and learning. We have learned from our experience over the years and now know that the solution to improving high quality emergency care and indeed sustaining that improvement lies not in emergency departments alone, but in the whole system of health and social care delivery working well together. That is primary, community, GP out of hours and secondary care. We have embarked...
1 minute.
I'll be 10 seconds.
Great.
We have embarked upon an improvement journey in unscheduled care. We are not yet where we want to be, but great strides have been made in the Western Trust, and we are absolutely determined to meet the needs and uphold the human rights of everyone who uses our services. Thank you, Chairman.
Thank you. I'm going to kick off and perhaps concentrate on Altnagalvin, and you mentioned the improvement plan, and the panel is familiar with the presentation that was done by all of the trusts at the kind of review day around emergency departments earlier this year. So I think my opening question really is to ask you to take us through what the problems were and the issues were that needed improvement. Then secondly, what exactly is the work that you're doing? And then thirdly, what are the things that you think are going well and you're seeing improvement in, and what are the areas, if you like, that is still work in progress and are still very much challenges for you? So if you take us through in those segments, problems, your solutions and how they're going, and what's working and what isn't.
Okay. I think it would be best if I were to ask Mrs. Mackay to take the lead on this, because, well, this is very much her passion, and Mr. McKinney, who's actually a doctor, as you know, will come in as well and supplement, because he has been a huge support to this project. Geraldine, do you want to say why we've done it, what the problems were?
I suppose the context of this piece of work goes right back to November 2012, and following the fire at Altnagalvin, the total bed capacity on site was reduced by 14 beds. And not only did we reduce the capacity by 14 beds, but included in that was the reduction of 8 single rooms. And I suppose we are a very small emergency department in terms of facilities and space. And the fact that we had that reduction in bed has actually contributed to the deterioration in performance at that time. So obviously we were concerned, and we thought by August 2013, when we were back to full bed capacity, that things would improve again, but in actual fact they didn't, and the performance continued to deteriorate right up to November 2013. And I suppose we looked at every variable that we could in terms of process, systems, workforce, how we were actually seeing and treating our patients, triaging who was involved in each step of the journey for that patient right through the hospital. And there was a number of variables, but there was no one thing that we could put our finger on that actually contributed to this deterioration. We knew our attendances at the emergency department had increased by 4%, but our admissions to beds had not increased. So there was no real indicator why this pressure was on and why we continued to have a poor performance. So in November 2013, and supported by the Health and Social Care Board, we secured the support of a critical friend, an expert from Manchester, who agreed to work with us and do a diagnostic data analysis for us. So he looked at our figures and our information for 2 years, the previous 2 years, and he came to the Trust in October. He came to our Trust and he presented to department managers, clinicians, our staff, facilities, support staff, right across, a spectrum of staff right across the hospital, presented an analysis of where he could see the issues were in our flow. And you will hear Mr. McGinney, I'm sure, at some stage tell you that this is not an ED problem. This is a whole hospital system problem, and that was proven. So from that, we...
Can I pause? Can I just say, Seamus McGarr, who was the external expert, came across for 2 days. On the first day, he presented the data to us, and I don't know if we've shared that in the information pack. It is. But it was very striking because, for example, he was able to demonstrate that the people who waited longest to be seen and treated in our emergency departments were the frail elderly. We actually had the evidence that they waited the longest. The younger, fitter got through quickly. It's not surprising, but the evidence was shown by that analysis. And so he presented this data to the group that you've talked about, Geraldine, and it was fairly hard-hitting, and people initially felt a bit defensive about it. And then he invited people to come back the following morning to say, how are we going to address these problems and who's going to exercise leadership and take these issues forward? And he asked people to come back at 8:30, and I went into the room at 8:30 and there was no one there. And in truth, I thought, they've all voted with their feet and they're not coming back to be part of the solution. And by 9 o'clock, there were more people in the room than had been there the previous day. And they apologised for the delay, but they said they were doing ward rounds and they actually wanted to get the patient flow right. But it was very hard-hitting, and really from that date, the second day, the ownership by clinicians, and I mean in the broadest sense, I mean doctors, nurses, AHPs, managers, porters, etc. The ownership in terms of we've all got to wrap around this problem was palpable. Sorry, Geraldine.
No, you're fine. I suppose just to continue on that day, the multidisciplinary working group in that room came up with 36 key actions. They have now increased to 40 given the Requia report and all of that, but at that point it was 36 key actions and that they would take forward. There was clinical people who wanted to lead teams and agree different pathways right across primary and secondary care, I have to say. The chair of our local LCG, who is a GP, was in the room, and he was quite keen that this work would go right across the patch, and that is what has happened. So out of the 40 actions, we have themed them into 8 themes, and you will have had in your pack those, I suppose, a representation of those themes. So that work began in earnest in April this year when it was launched, and the 100% day was, I suppose, put to us by Seamus around June time. We were quite anxious about it. The chief executive was very anxious about it because we didn't want to put something to our staff that may fail, yet we knew we had to boost our staff and give them something to work towards. So we did that. And I suppose the 100% day happened on the 12th of September, as you will have seen from the media coverage and the communications. And really, it was a stress test, as the media reported it, a diagnostic for our system at Altnagalvin to see whether we could do it. And we did. It was very successful. We asked our staff to go the extra mile. We did some things differently that we wouldn't normally do. We had in place, where there would have been gaps in rotas. We filled the gaps. We made sure they were filled. There were senior managers all day right through to midnight. We were worked very closely with our primary care colleagues from the Monday right through in terms of preparation and planning and making sure there was, our delayed discharge were at a reasonable level, all that sort of thing. So the NIAS, we had the Northern Ireland Ambulance Service on board they give us a person for the day, a HALO, it's called a Hospital Ambulance Liaison Officer, which we do not have in the West, and we're the only trust that doesn't have them at this stage. So we were supporting our staff, I suppose, to go that extra mile to try and come up with what it would be like for patients if we had everything in place on a day. Could we achieve 100%? And we did.
Yeah, I was just going to say that what we were really doing was testing some of the assumptions within the work programme. Effectively, we implemented our programme, and this was a test to see whether the work is moving in the right direction and whether we can look forward to improvement as we implement the various strands.
Do you want to say, Alan, some of the key things you've done? And as I say, I'm interested in what's working, but also in what hasn't worked in quite the way you anticipated. So I wonder if you could hone in on some of the things, that the changes you've made, the key ones from your point of view.
Well, I suppose fundamentally our concept is that blockage in the emergency department is a symptom of lack of flow through the entire system, from primary care right through to discharge and rehabilitation in the community. So our work programme involves aspects of all of those components of the journey. The things that often lead to delays in the emergency department and particularly affect the elderly patient group are delays in admission to medical units. It sometimes feels in the emergency department as if the emergency department is working faster than other parts of the service, and that if this was a conveyor belt, that the different parts of the conveyor belt are running at different speeds. So fundamentally, we wanted to try to see whether we could match the speeds so that we could anticipate the number of admissions and match the number of discharges from the various units back to the community, so that there would be bed capacity and therefore no delays for those requiring beds. We also wanted to look more carefully at the admission profile and make sure that we are admitting the right people for the right reasons. One of the difficulties, I think, in an emergency department is that when it gets congested, the function of the department changes slightly. Rather than being a diagnostic area, matching patients' requirements to a range of options, sometimes it feels as if the issue becomes how do we clear the queue, and the default position for that sometimes becomes admit the patient to hospital, because that's quicker than making contact with community services and trying to arrange alternatives. So we wanted to untangle the decision-making process to assess the importance or otherwise of senior decision makers at the front of the process when they weren't under pressure, so as to see what different decisions could be made, what alternatives to admission could be arrived at. We also wanted to look at the interface between the A&E department, the emergency department. I'm an old-fashioned A&E consultant. The emergency department and the acute medical unit, and also the interface between the acute medical unit and the various specialties, because those are essential components in this flow process. Clearly, the specialties accepting patients from acute medicine need an output, and that usually means discharge. And because the bulk of our admissions tend to fall in the elderly age group, often their needs are complex and require planning. So it was really essential that we had in place care plans for those who have slightly more complex needs into the future. I think one of the really successful parts of the 100% day was the way that those various components lined up and functioned as one unit. And it reaffirms, I think, in our minds the pathway, the direction of travel that we are currently on, that if we can ensure that patients are discharged in a timely manner with appropriate arrangements in place, that we can reduce their lengths of stay we can free up capacity in the specialty beds, which will allow the acute medical unit to move patients through the process in a timely manner. We also, I think, were interested in seeing whether the model for acute medicine could have a slightly different emphasis, because a lot of the decision making in acute medicine is broadly similar to that in the emergency department, in that the decision is, do we send the patient home or do we admit the patient? And there are a range of options in between those, which acute medicine could and will develop, including ambulatory clinics, allowing people who require investigations to go home, awaiting investigations or awaiting the results of investigations to come back. One of the areas that has been problematic in that is that we wanted to avoid using the outpatient facilities, because it's very difficult to control the rate of return to an outpatient service. So if someone comes in, has, for example, a CT scan, they and their family will be anxious for a result. We can't put them into a 9-week queue for an outpatient clinic, so we need to create facilities where the acute physician could perhaps see that patient in a couple of days' time in a guaranteed, structured way, so that the pathway avoids the need for a bed in the first place. So it's about more efficient use of the resources, making use of alternatives to admission, and ensuring that for those who are admitted, that the flow is coordinated and that the whole system is involved in that pathway. So there are a whole range of things. I think that we were very, very heartened by the fact that despite the fact that the A&E department is a very small department with a relatively small number of staff, that on the day that everything lined up and our assumptions were in place, that the system did actually work in the way that we had hoped.
Can I, in terms of your question about what specifically have you, and I think we knew some of this, but we now have evidence for it. I think that's part of the importance of the 100% day. And I mentioned in my introductory comments about the fact that we have got the fewest number of ED consultants in Northern Ireland. So when I attend the College of Emergency Medicine summits, and the president, who I know gave evidence to you, says that there should be 10 consultants for these type 1 EDs. We currently have 4 in Altnagalvin, and that's 3 permanent and 1 locum, and there's another permanent one starting in January. So that will give us 4 permanent and 1 locum, which is half of what the College of Emergency Medicine is saying we require. So when I talked about a local solution, there's no way with only 5 consultants you can provide consultant cover 24/7 for an emergency department. So the decision has been taken that what we need to do is to put additional resource into the medical workforce that pulls the patients from the emergency department into the beds. Either the beds for analysis, as Alan described in terms of acute medicine, or an emergency decision unit, and we find that is making a real difference. And to be frank, because this is a learning process, our experience, and I expect that Marion will understand this with her background in terms of knowing the West as well. Our experience is that with very limited numbers of trainees coming through, and other emergency departments growing in the Greater Belfast area, they soak up all the trainees who are coming off the training scheme. So that ain't going to fix Altnagalvin. We're not, over the next few years, going to be able to recruit. So a priority for us is to strengthen the assessment of our patients and to find facilities where they can be comfortably supported while assessment takes place. The ambulance one that we talked about is terribly important. Now, we are going to make a case to have this halo. I've actually spoken to the Ambulance Trust in the past week about this, because the ambulance liaison allowed very quick flow through, and this was happening in the very week that a patient died in the back of an ambulance in Wales. So everybody was very conscious of the importance of the liaison with them. So, and the other thing I would say is the workforce overall, and I'm hoping that Dr. Steele and Mrs. McClintock, who will be giving evidence later, who are the front line of the service, will talk more about the workforce, and Geraldine referred to this. The workforce we've got, they are exceptional and they're very committed, but they're tired. They've been trying to achieve the standard for a very, very long time, and in a sense I would describe it as we have a deal with them, and the deal is you keep trying your best to show how good we are and how committed we are, and we'll do the things that will help you to do your job better. And I suppose what we would like to do is we would like to have more opportunity for our staff to be developed, to increase their skills. Geraldine and Alan Corey-Finn, who's our Director of Nursing, who's here today as well, wants to create the advanced nurse practitioners to supplement the emergency nurse practitioners. So we have all of these aspirations, and the 100% day affirmed that we are heading in the right direction in terms of the diagnosis of what we need.
Okay, can I move on to a couple of ancillary issues, and then I will pass you on to Marion. A couple of things. Outlook Government used to have a kind of direct admission, as I understand it, and that had kind of stopped. Is that part of the new planned arrangements? And if so, what role does that play?
Well, no, I was just going to say Monday to Friday and Saturday, I suppose we have a trolley bay as part of our acute medical unit, whereby GPs can directly send patients without them coming to A&E at all for assessment and admission or discharge. That unit runs from 9 a.m. to 7 p.m. in the evening, so therefore that does take some of the pressure from our emergency department. I suppose Elaine has spoken about our emergency decision unit that we would like to put in place, and the aim of that unit would be to carry on that work overnight 24/7, so that we have an alternative route for patients into the hospital. We also require I suppose a means of avoiding admission to our beds, so the purpose of that is that, but there's no direct admission to a ward. They either come there or they go to the emergency department. We also have in place now a surgical assessment area since July of this year, whereby GPs, with a surgical patient, can refer a patient to the hospital, bypassing A&E as well, to the surgical area for assessment and or admission and discharge.
I think our analysis is that where a GP has seen a patient and feels that they require admission, that the emergency department doesn't add any value to that, and that elderly patients in particular are very disadvantaged by having an additional unnecessary step in their pathway. Where a GP wants a patient to be admitted to or seen by a physician, that the simplest way for us to operate our system is for a direct referral to that specialty. And that also has the advantage that it reduces the pressure, the unnecessary pressure in the A&E department, and allows the A&E department to focus on the important core parts of emergency medicine, which often get overlooked when the queue builds up.
Okay, thank you. Then a question which is more difficult and a conundrum for us in terms of the panel. One of the issues that we have had evidence on has been, and was part of the RQIA report, was the notion in Belfast that there was a bullying culture, and therefore that was part of one of the issues that was faced by the Belfast Trust in particular. And the evidence we've had to date has been from managers and senior managers is that that's not generally an issue across the trusts. The evidence, on the other hand, we've had from staff representative organisations, from the trade union side, from the Royal College of Nursing, from BMA, is that is an issue. And I'm struck by, and we will not get to the bottom, frankly, of whichever of those perspectives is the right one. But what I am struck by is that in evidence we would say, well, if there is issues of bullying or a bullying culture, then it's very hard to have participation and involvement, because if people feel inhibited in terms of those issues. So my question, I think, is one, is that an issue for the Western Trust? And if it's not, have you any sense of why there is such a disconnection between the evidence we're getting on the one hand from management and the evidence we're getting from staff representatives?
Okay. My background before becoming a general manager was as director of HR. Yes, so people and happy people is my business. And indeed, the aim of our trust, which has been adopted by the trust board, is to provide high quality patient and client focused services through well-trained staff with high morale. And that is a very, very firm objective for us. I think there's a disconnect because undoubtedly we are put under pressure to attain the target. So we go to regular performance management meetings at the Health and Social Care Board, where our performance against the 4-hour standard is monitored. And then we have accountability meetings twice a year with the department where discussion takes place, and we're put under quite a bit of pressure in terms of what could you do, could you not do better, could you this, that and the other. Now there's a real risk that whenever we when we feel the weight of that we then translate that to our staff. And this is a very tricky one because we are working really, really hard to attain the standard because it is in the patient's interest. We absolutely accept that. But in our desire, our passion to achieve the standard, some members of staff may well feel intimidated or bullied or harassed. However, it certainly isn't the feedback that I'm getting directly from the staff, and of course Dr. Steele and Mrs. McClintock won't say anything different because I'll be sitting in the audience. I'm sure they won't feel empowered to say she's dreadful, but I can say that at one stage we know when the Royal College of Nursing came to Altnagelvin's A&E department at a time when things were very tricky across Northern Ireland, and the nursing staff spoke to the representative. The Director of Nursing, Alan Corey Finn, and Mrs. Mackay went immediately over to the staff and said, look, tell us, you don't need to do it through your professional association or trade union, what are the things that are worrying you and what can we sort out? And interestingly, it was the old hygiene factors. It was we're working long hours, could somebody organise so that we can get a break and a cup of tea or something to eat? And they were able to sort that out. So we try to create open lines of communication. And Alan Corey Finn has established a model called Beyond the Grapevine. So let's not all allow rumour to set our culture. Any nurse in the Western Trust who has concerns can raise concerns directly with the Director of Nursing, either anonymously or in a meeting, and we're really working hard to try to address this issue. But I do accept, Chairman, that inevitably there will be some people in your drive to achieve the standard who feel intimidated or bullied.
Okay, thank you. I'll pass you now to Marion.
Good afternoon. I only want to find out a wee bit more about staffing in South West, because you've mentioned your consultant cover in the Altnagelvin, which is 4, one of them currently in locum, and 1 due, which is 50% of what's recommended. And I'm just wondering, could you outline what the statistics are in South West?
Yeah, we have 3 whole-time consultants in the South West Acute Hospital for about half the patient numbers that are coming through. So I said we had 59,000 patients in Altnagelvin, and we have 30,000 patient attendances and 3 whole-time consultants. I would say, and I know Joe Lusby, who's my deputy, will be speaking at the meetings in Omagh and Fermanagh. I would say if you were to ask in the South West Acute where they would like to see more investment as a priority, it would be in nursing staff there rather than in medical staff.
So you're content that the A&E medical cover in South West, whether is it all locum or
no,
they're all permanent staff?
In addition to the 3 consultants, the senior rota is augmented by an associate specialist who's been there for about 20 odd years. The big difficulty in medical staffing in South West Acute lies in the junior and middle tier. some years back, before South West Acute was created, whilst it was the Erne Hospital, we went through a very difficult period when training recognition was withdrawn, and we have suffered greatly as a consequence over a number of years. Following that, the junior doctor tier was effectively replaced by a middle grade, staff grade tier of doctors. And that was always very difficult to fill. There were often gaps which were filled by agency staff. At the time that we changed services in Tyrone County Hospital, some of the middle grade staff who worked in Tyrone County were transferred to the Erne Hospital, and that helped to improve that service. Unfortunately, I think nationally and not just regionally, the demands of emergency medicine have driven a lot of middle grade doctors away from the front line, and a good number of them have actually moved into agency locum work. It's effectively the same work, but at a very, very different rate of pay. So currently in South West Acute we have an establishment of 7 middle grade doctors. Of those, currently 4 are agency staff. 1 is non-agency but temporary. We also depend on casual agency staff to fill 2 posts, and we have a GP trainee who has been allocated by the Northern Ireland Medical Dental Training Agency to South West Acute. So that really, I think, is the biggest challenge for the staff. We have very, very committed consultant staff in South West Acute who have a different working pattern, I think, than you would expect in a larger A&E department. They have less administration to do for a smaller department, and therefore have more availability for clinical work. I think uniquely in Northern Ireland, the 3 consultants and associate specialists that are there are able to provide much greater frontline direct clinical care over a wider period of time in the day. So it's a unique arrangement, but it works in South West Acute's environment and allows us to maintain the high standard of care that's there.
Thank you. I have only one question, and it's really drawing on the experience you had from your 100% day and how responsive the service is to patients. And I'm wondering, could you outline how you plan in the future to improve the ED journey for patients such as children, those with dementia, or those with chronic long-term conditions, using that whole system approach, which you really mobilised that day in a significant way?
Yes. And I would like to say, I'm sorry for calling you Marion earlier, but
It's
Marion used to inspect me years ago when I was in Foyle, and I would like to think that because I have come from a community trust background, I absolutely understand the difference that effective community services make to the efficient running of an acute hospital. I think we have got lots of good stories to tell about what we are doing currently in this area and how we propose to even improve further. I'm going to ask Alan maybe if you would say something particularly around dementia, etc.
Yeah, I think that one of the unique things in the A&E department in departments in the Western Trust is that we have over a very long period identified particular needy groups who have specific needs within the emergency department. Clearly, there are standards that have been set by the College of Emergency Medicine for children's care. We have a children's area that was created, I think, about 7 years ago in Alton-Gelvin, and the new South West Acute department has a children's specific area. However, I think none of us want to see children waiting in an A&E environment. We only have the children's area open during the day when we would expect the peak numbers. And what we do with children, and have always done with children, is to triage them upwards so that they are seen as they arrive effectively. An adult waiting room is a completely inappropriate place for children and their parents when they are in a distressed state. We do have aspirations to have an expansion of the A&E service in Londonderry with as part of the redevelopment of the site. And at that time we will have a separate children's facility. But in the meantime, we are muddling through with a combination of triaging and providing facilities where we can. The staff in the A&E department have always sort of seen children as a particularly important group and have provided a range of initiatives. For example, we have an arrangement where disposable teddy bears are available to all children arriving in. We can't give them reused teddy bears because of infection risk, but we've had an arrangement where we are supplied now with fresh new teddy bears for each child who requires one. We are particularly careful about analgesia in children, ensuring that they are dealt with quickly. And our staff actually go out and buy ice pops, which we keep to encourage children when they behave in the directions that we want them to. So I think children are a very important group, and a group that are sadly overlooked in many A&E departments. The reality is that a third of our workload in emergency medicine relates to children, although the vast majority of those children present with minor injuries. In terms of the more seriously affected children, we have special arrangements with the paediatric unit so that, for example, seizures, children with seizures are admitted directly to paediatrics without stopping in the A&E department, and that arrangement has been in place for over 10 years. It works very effectively in reducing the anxiety and shortening the journey for those children who will inevitably become inpatients anyway. Turning to some of the other groups, there are a number of groups that I think have particular needs in the adult population. Elderly patients we've briefly touched on. Another group that I have serious concerns about are those who are homeless. Many of these people have no other access to healthcare, and although in some areas they may be seen as nuisance patients, I think that the emergency department have a really important role in providing primary care when the opportunity arises. So we've always taken the view that these people should be treated as individuals and provided with the best possible care when we have an access to them. We've had relationships for a long time with the local hostels for the homeless, and we in fact for a good period actually funded some beds in one of the local hostels to ensure that we had direct access. Moving upstream, I suppose a lot of homeless people are homeless, and part of a component of their difficulty relates to chronic alcohol use. And moving upstream from that, way back I think in 2007, we ran a pilot embedding an alcohol liaison nurse within the A&E department, where our staff could have immediate access for patients whose attendance in A&E was directly related to their risky drinking behaviours. And we've now had that firmly established and permanently funded, and we've rolled it across the inpatient specialties as well, so that a patient coming in with a fracture or a fall or an injury of one sort or another, there is an opportunity, a very brief window of opportunity to connect their ill health with their risky alcohol behaviour. And we've demonstrated that we can reduce by up to tenfold the number of attendances subsequently in the A&E department. So that sort of proactive approach with this group, I hope, will eventually feed through to the chronic alcohol population. Falls in elderly people is another. We often have people who are infirm and perhaps vulnerable to falls. And clearly where somebody requires admission, then there is a process within the trust and a full falls assessment service, which is organised and coordinated by the Care of the Elderly team. But there are also a group of people who have fallen or who are unsteady, who don't require admission at that particular moment. And a number of years ago, we made a connection with the Derry City Council, who have an environmental officer who has a remit to help us with looking after assessment of these patients. So with the patients' and families' permission, we will make a connection to the council they send their assessor to the home and check for simple things that would help, for example, lighting, loose mats, smoke alarms, automatic lights switching on and so on, that may help to alleviate some of the risks. And they also have a range of equipment that's available, including handrails and so on, that otherwise wouldn't be available to this group. You mentioned another very vulnerable group, which are the dementia patients. And we have concerns about dementia patients, which I suppose were highlighted in a recent serious adverse incident for us, where a dementia patient who was resident in a nursing home was sent to the A&E department without direct supervision and managed to leave the department before being assessed and found his way back to a previous address. And it made us realise that dementia patients don't look any different to ordinary sort of adult patients in a waiting room, and that we need to be able to easily identify people who are vulnerable and at risk. So the Trust has recently introduced a purple folder arrangement, and that runs across the entire Trust, where the staff are alerted to the presence of a purple folder. We all have purple folders ourselves. As people with particular cognitive impairment who may need an additional bit of help. And I think that subtly points these people out to our staff and ensures that they aren't overlooked in a waiting room or in a busy A&E environment. There are a couple of others that, if you've got time for me to describe. Mental health patients, I think, are another group who are often badly managed in A&E departments, and effectively often it comes down to a decision, do they require admission to a mental health unit or are they going to go home? And I think that there are a whole range of options in between. So we've forged links with the community psychiatric nursing team to provide rapid assessments for patients, and that service has expanded in terms of the hours of availability to us, so that we now have 24/7 availability of CPNs. But added to that, we also, the year before last, introduced an arrangement which we call Card Before You Leave, which is intended for people who are deemed fit to go back to the community, who perhaps have come to the A&E department in a crisis, but we've been able to sort some of the issues for them. And the idea of the Card Before You Leave is that before they leave the A&E department, whether they leave of their own choice or we are discharging, is that we send them home with a very specific appointment with the community team, so that everything is in place, the community team are alerted and are ready to look for them the next morning. And I think that often is a concern for people within the A&E department, that sending people back to the community who have particularly sort of emotional crises, mental health crises, can be a very dangerous step to take, and sometimes it results in people being unnecessarily admitted to mental health units. So we have some other links. One of the ones that I'm particularly proud of in the A&E department is that in 2009 we were able to persuade the Health Promotion Agency to embed a researcher within the A&E department, and that's now a permanent feature. And her role is to analyse our database, and particularly with an interest in elderly patients and children, looking for trends in attendance. Most children's attendances are going to be as a result of injuries, and we are able to pinpoint particular issues that result in children's accidents, and feed that information back to the community through Sure Start or the mothers and toddlers groups, to the local home accident prevention committee and so on, so as to try to avoid some of the unnecessary injuries that happen. The elderly population's attendances that we focus on tend to be about home accidents and specifically about falls, and so that was effectively what caused us to look at the Derry City Council environmental service. So we have these things, and I think that I would characterise our approach to emergency medicine here as being much more community orientated and holistic, than perhaps you'll find in other areas. And I think that by removing some of the medical assessment, unnecessary medical assessment from the emergency department environment, we can return to those core important values that prevent accidents and can actually improve our connections into the community and avoid attendances in the first place.
Thank you very much. Thank you.
Okay. Paul.
Thank you very much. And can I just do a quick check in terms of timing? What shall we? Because time is marching on, and these are busy people. What do you suggest?
Well, if you're okay for time, I'm going to suggest that we don't take a break after we go straight to the second of the, and then we'll take a break at that time. So I think our timing is okay, and we can manage our time this afternoon. So don't feel inhibited. If you're happy enough to.
Oh, I'm in your hands.
Okay.
Okay. Thank you very much. I'm conscious of the dedication, care, and compassion of a great number of health professionals. I noticed, Elaine, what you said about some of them being tired, but nonetheless, that dedication, care, and compassion is palpable for many health professionals. I'm also conscious that the current health system structure is, it seems to me, sort of relatively new. I mean, relatively new, 5 years or so. And I think for a large, complex system, that's relatively recent. So the point I'm making is that the system is still maturing. And I think that's an important point of context. I'd like to focus on some of those some larger systemic issues rather than the clinical issues, because emergency care is located within this larger, maturing system. And the system is complex, it's large, and there are a few pieces of the jigsaw that I haven't yet got quite clear. So if you can help me, that would be really very much appreciated. One piece of the jigsaw that I haven't got clear is the role of the local commissioning groups. And these are, of course, committees of the board. They're established by primary legislation. They're really important. Could you, I know time is short, but could you just help me understand how they work in your trust, at least?
I was going to say, have my colleague chief executives not been able to explain this previously? Well, the local commissioning group, how it works is there is an assistant director of the commissioning board in Belfast who is based locally at Granshire Park House, and he works with a chair of the LCG who comes from primary care background, and the membership of LCGs includes people from the community, etc. So there's a board, without it being established formally as a sort of non-executive board, there's a board of individuals who cover the geography of the Western Trust.
And who appoints them?
Those would be appointed by the Health and Social Care Board. They'd go through an interview process. The posts would be advertised, and they would be appointed by the Health and Social Care Board, because, as you quite correctly said, it is a committee, a subcommittee of the Health and Social Care Board. They work very closely with us as we try to design our pathways of care, and I would say that we are very fortunate locally because we have a local GP who is the chair, who works so closely with us that he is actually a member of the Unscheduled Care Improvement Board, so he's very much working with us. But they will influence investment in our services. So, for example, one of the things I'm sitting here with today is a letter that has been sent from our organisation to the Health and Social Care Board in Belfast, to the Director of Commissioning, which says, in order for us to sustain improvement in emergency care access, we need the following, some of the things that we've talked about today. Now, that Director of Commissioning in Belfast will go to the local commissioning group and will say, local commissioning group, do you agree with the local provider that these are the priorities, or might you change the priorities? We have said one big priority is about doctors who are specialty doctors rather than ED. Do you agree with that? And that will be tested. So part of our role is we work very closely with them. We'd work with the LCG on a weekly basis where we try to influence them to support our priorities, and they challenge and push back on us. They don't have a lot of money, but they have more influence. So if it's big money that we're looking for, we look to the Health and Social Care Board in Belfast.
Right.
Is that anything you want to add?
I suppose in my role as director, I work with them day and daily.
Yeah.
You know, we would discuss the gaps in our service provision and how we might close that gap.
Right.
And we look at different models, and we look at pathways, for example, for patients that avoid them coming anywhere near the hospital. And one of the biggest successes, I suppose, in working locally with the Commissioner has been looking at pathways for patient gastroenterology that stops them ever coming near the hospital at all. So it takes it right back to primary care, so where they're looked after in the community with the support of our consultants.
And roughly how many are on these LCGs? How many people?
I think there's about 15 members
15.
on it. Yeah. We tend not to deal with their board, if I can describe it in that. We deal with the officers of the LCG.
Right. Meaning the chairperson, secretary...
And the assistant director of commissioning,
Right.
yes.
Right. And are they, forgive my ignorance, are they, they're full-time in another capacity, they've got another job which they're doing, no?
No,
The
GP has another job.
Mm-hmm.
Yeah.
The others are full-time staff.
Commissioners.
Commissioner
Full-time
staff.
commissioners.
Mm-hmm.
Right. One, thank you very much. And your
that helped.
your colleagues in other trusts have helped hugely on a number of issues, and it's no fault of theirs that I haven't quite grasped this bit of the jigsaw.
I'm not sure that I have, as you can hear from them.
But one of the issues that I'm interested in is what the papers call personal and public involvement. So in this document, the framework document of the department, for instance, there's this really important, it seems to me really important, paragraph 5.1. And I'll just, I'm sure you know it, but not everybody here will know it. So I'm just going to read out, if I may, 3 sentences. So this is an important document coming out of the department, right? It's the framework document, and it says, patients, clients, carers, and communities must be put at the centre of decision-making. This means they must be properly involved in planning, delivery, and evaluation of their services. The HSC bodies are accountable to people and communities for the quality, accessibility, and responsiveness of the services they plan and provide. So a really strong statement, very elegantly written actually, about personal involvement, community involvement in planning, delivery, and evaluation. And then I'm trying to understand the LCGs, and you've helped enormously, Elaine. Thank you very much. But when I look at the framework document about LCGs, it says things like they have as you said, Elaine, they have a lead role in the strategic commissioning process, in particular, having helped to shape strategic thinking, to apply it locally on behalf of their populations. They have responsibility for assessing health and social care needs in their areas. The LCGs identify local priorities, taking account of the views. This is a sentence I'm interested in. LCGs identify local priorities, taking account of the views of patients, clients, carers, and the wider community. So I'm trying to get a sense of whether or not the LCGs, they do a really important job, don't misunderstand me, and you've just made it clearer for me. And so I'm not knocking them. Please don't misunderstand me. They play a really important job and they work really hard. That's obvious. That's clear to me. But what I haven't got clear yet is whether or not they're providing this link into how they're taking into account the views of patients, clients, carers, wider communities, and service providers. And I'm talking too much, but if I could elaborate a little bit more, it seems to me that another really important mechanism to action paragraph 5 are the non-executive board members on your trust. And I think there are 6. And if I understand it correctly, some of them might be here, and if I understand it correctly, they tend to be, I'm not talking specifically about your trust, right? I'd like you to educate me about that. But the non-executive board members, they're highly professional, they're dedicated, they bring great expertise to the board. But I'm getting the sense that they're not always closely tied into the communities and reaching out into the communities to get their views and reporting back. So I'm trying to get clearer in my mind how paragraph 5.1 is really actioned. And one way it might be actioned is through local commissioning groups. And they play a really important role, but I'm not yet hearing that they're reaching out into communities. And another way that 5.1 might be actioned is by the non-executive board directors. Terribly important, I esteem them greatly, but I'm not yet hearing that they reach out into communities and then bring the views back. So could you, perhaps I'm misreading it, misunderstanding it, could you comment on this issue of 5.1 and the outreach to the communities, engagement with the communities?
Yes, I think it may well be that the inquiry would wish to speak to some LCG representatives about how they do it. I wouldn't be overly critical, certainly, of the Western LCG, because I am aware of areas where they have really reached out to the community. Right. So, for example, when they were reshaping GP out of hours services, they did an awful lot of consultation right across the geography, and of course a lot of resistance to any proposals to change, etc., etc., and they were right on the front firing line. They also do work very closely, particularly because of the link with the Public Health Agency. They work very closely with community organisations to aid community development, and actually in many ways they are encouraging providers in the voluntary sector to provide services to communities when we might wish to say to them, you wouldn't ever spend that money with us rather than with them. So certainly in terms of our local LCG, I think you could establish evidence that they have reached out to take the temperature from the community. The personal and public involvement is an area actually that the Western Trust Board is passionate about. I would say that perhaps, but I really genuinely believe it. What we have done in our organisation is we've separated out the personal and public involvement from patient experience. The Director of Nursing leads on patient experience. The Director of Performance and Service Improvement leads on personal and public involvement. But the Chairman of the Board has nominated one non-executive director who may be known to Marion Stella Cummings, who is a social worker by background and from the Limavady community, and she leads on this specific area. And we would have literally hundreds of events across our geography throughout the year, and Stella would attend the major consultations. She co-chairs the group with a patient representative and feeds the personal and public involvement group. Right. And she would feed back regularly in public at Trust Board meetings about the issues that are coming up. We have established we've introduced patient stories being given at the start of every Trust Board meeting in public if the person is content with that, and that allows the non-executive directors in particular to get a really good feedback in terms of how the patients have experienced our services, and we've deliberately done it on the basis of it should not be all good news stories, which is why I'll be interested to hear what we hear today. We need to learn, we need to improve. All of our non-executive directors have been appointed because they have skills, but they also have a geographical representation. And I can say, for example, when last year we had the issue of the potential closure of some residential homes, which the Minister paused on, each of the non-executive directors who lived locally made representations to the board, quite interestingly, not from the point of view of what I have, I hold, and it has to stay, but a very mature discussion about the needs of older people in their communities and what such a change may mean. And that's all on the public record. That's in the minutes, so that can be viewed.
So would those, this sounds very impressive, but
Yeah.
would those non-executive board members, I know they're from those communities, but
Yes.
would they have gone to the local community and say, look, we have a problem here, this is being suggested, there are financial constraints, I understand that they reported to
Yep.
you, and
Yep.
which is terrific.
Yep.
Again, I'm not knocking it.
No.
I'm trying to get a sense of whether or not that they saw it as part of their sort of job description, as it were, to go and meet with people who are in that residential care home and their families to talk about this challenge.
Yes, they did. They
Okay.
did. And also, can I say, and again, those members of the Commission who live locally may be aware of this, but we made very significant changes to the profile of medical services in OMA some years ago. And the local non-executive director from OMA made it his business to connect with local people in the community to find out what their concerns and fears were and to represent those at our trust board meeting so that those could be discussed. We had a very, very difficult time in OMA, but we've moved on and we've taken on board some of their concerns. I want to say this, I have been in the health service forever now, and I absolutely know that every bit of feedback I get is only to try and help us improve. And what I want to say is that every single formal complaint that comes into the Western Trust, I see, I read, and I respond to.
Yeah.
And I think that's invaluable feedback from the people who use our services. Sorry,
But I'm not to be. I mean, that's very helpful and very interesting. I'm not talking about complaints. I'm talking about just
people's involvement in the
engagement in the community, so that they know what's going on and they can make their own contribution. So I know I have to stop soon, but in this framework document, there's talk about the different roles of personal and public involvement, and the PHA has responsibility for ensuring that trusts meet their PPI statutory and policy responsibilities. And there is a PPI forum chaired by the Public Health Agency to establish for this purpose. Could you comment, I'm sorry to ask you to be brief, but briefly on the PPI forum and how, in your view, that's working?
We have one of the assistant directors of nursing actually attends the PPI forum. I would say in terms, and this is me just being absolutely straight, I would say in terms of PPI, our priority is actually our internal work. We give account of what we're doing at accountability reviews, which include the PHA and the Health and Social Care Board and the department. So we will give account of the progress, but we've taken the view that if it's going to be real and meaningful and change what we do, it has to be local. So we go to the regional meetings, we contribute, we say what we're doing, we pick up best practice. The PHA's 10,000 Voices campaign has been invaluable in terms of quite an independent assessment of what people want from the services, and that one I would say we would hugely commend the PHA for taking the initiative on.
So what happens at the PPI forum? So one of your directors goes?
No, an assistant director would go to it. So basically what would happen would be the PHA would say, these are the things that we see as the priorities to take forward. Each of the trusts would say, well, here's what's happening in our organisation, and there may well be a discussion about, that looks like a good idea, we'll try and roll that out across Northern Ireland, or that's specific to your area, it might be very local. It's really a learning and sharing forum.
A couple of times a year? It meets a couple of times a year?
I'm not sure how often. I'd say maybe 4 times a year.
Yeah.
Maybe 4 times a year, I'm not quite sure.
Okay, well, I had other questions, but I think I've gone on for too long and we're running out of time. So thank you very much.
Okay.
Elaine and colleagues, thank you. Is there anything you finally want to say before we close this session? Anything you think we haven't covered?
If you wouldn't mind, I would like to say something about the money. Is that okay?
Yes.
Okay. So the Western Trust is given and spends £560 million a year. The entire budget for emergency care in Londonderry, the Type 1 ED departments, so not including OMA, the entire annual budget is 5.25 million. out of the 560 million that we spend. It's not enough to meet our needs, and we are, as you all know, in very straitened times financially. And the Western Trust, like every other trust in Northern Ireland, is reporting a very significant overspend at the end of month 5. We'll report that in public next Thursday, but at month 4 we were reporting almost £13 million of an overspend. Emergency care and safe, high-quality care has been prioritised by Trust Board, and if we continue to spend as we have spent up to the end of month 5, we will actually have spent 7.15 million on emergency care. That will be an almost £2 million overspend on a £5 million budget. That is very significant, and I share that with you just as real evidence that we are determined to get the emergency care pathway right. I think as Alan McKinney spoke, you will hear the values. It's very much about a lot of the people who come to our doors are the most vulnerable members of our society, and we just feel that they need to be prioritised in terms of their care. So poor financial performance in this area for the right reasons.
Okay, thank you. We're particularly interested, I think, in a number of the initiatives that you've mentioned, and as we've said to everyone who's given evidence to us, we'd welcome any additional written materials. I'm particularly interested in kind of the implementation of a number of those initiatives. So if you have that kind of material, that's particularly useful. And apologies for keeping you waiting, but thank you. We have overrun, but I think it's actually been a really useful session and worth doing. And what I will suggest is we move straight to your colleagues, and we won't take a break.
Thank you very much.
Thank you.